So once you have basically in your hand, you have the definitive diagnosis that what exactly you're dealing in with, then you would plan for a particular kind of a treatment in these cases as well. So the treatment is going to depend upon the kind of the carcinomatous condition that you're dealing in with, whether it is a benign or a malignant tumor, or whether you're just going to resort to a symptomatic treatment in the patient. For prolactinomas that we're dealing in with in our case study, we can resort to the dopamine agonists as well. For the patients who are showing or exhibiting the signs of acromegaly, we usually resort to the somatostatin analogs particularly. Then we have the growth hormone receptor antagonists if we are dealing in with a somatotrophic tumor. But particularly for the TSH secreting tumors. These somatostatin analogs can be used for the dopamine agonists, and we can resort to the ACTH secreting tumors and non-functioning tumors, in which we basically resort to surgery, or even if they have pressurized symptoms after the surgery, we can couple up the surgical treatment along with the irradiation therapy for these patients. Sometimes patients respond very well to the irradiation therapy alone, and we can basically delay the surgical treatment to some other time until the patients have the basically we're dealing in with the non-functioning tumors, so we can just resort to the irradiation therapy in a lot of cases. So it's basically going to depend upon the set of the signs and symptoms that we have in a patient, and accordingly we're going to treat the patient symptomatically, and we are also going to basically evaluate the risk versus the benefit ratio in a particular patient. Either we can opt for a surgical management, and sometimes we can even opt for the irradiation therapy alone.